Hi everyone, hopefully this is recording. This is the lecture on prenatal concerns or prenatal development concerns, where we're in our section where we're looking at motor development and looking at factors or influences on people's motor development and how that develops. So in this lecture, there's certain things we're going to pay attention to. We're going to describe three major phases of prenatal development. We're going to describe the possible effects of drugs and medications on the mother and the developing fetus. We're going to identify the possible effects of maternal diseases on the developing fetus and describe one of the most common genetic factors known to affect prenatal growth and development. And then we'll look at some prenatal diagnostic procedures and describe the advantages and disadvantages of those. So I must warn you, it's not the most, it's not the happiest lecture. It's not great information because we're dealing with things when they go wrong. But recognize that usually things go right. However, as professionals in the area of working with people in either motor skills or some kind of development or rehabilitation setting, I think it's important that you're educated on some of these concerns and what can happen if things aren't done correctly during pregnancy. So we're going to look at factors that negatively influence our growth and development, and we're going to look at both genetic and environmental factors. Now, some researchers have tried to state how important these factors are on any kind of prenatal development issues. One study that I looked at said that 10% of birth defects result from environmental factors, 25% of birth defects result from genetic factors, and then 65%, which is obviously a large number here, of birth defects result from unknown agents. So we don't really know where they might come from. You probably won't be able to see this too well, and I'm certainly not going to ask you any test questions on the content in this diagram on this slide, but it does show you the three main periods that we're going to look at and how the fetus develops within those three periods. And what's really interesting in this slide is that it does show or illustrate the critical periods in human development. We see that during the first 2 weeks of development, which is to the far left there, the embryo is not usually susceptible to teratogens, and I'm going to define what a teratogen is in the next few slides. However, as it moves into the next few stages, any types of defects or environmental agents can cause problems for certain parts of the body or certain organs that are developing during that time period. It's what we call critical periods in human development. So if there's an issue or a teratogen, which is this unfriendly agent entering the body during a certain time period, it can result in very specific defects to certain parts of the body that are developing during that time period. So let's look at those three major phases of prenatal development. And what experts in this area have done is they've broken down the development of the human organism into three major phases, which is the germinal period, the embryonic period, and the fetal period. So if we look first at this germinal period, this is the first 2 weeks after conception, and here we talk about the zygote, which is the new cell that is formed by fertilization. So this is right at the start. And we know that if a teratogen, and a teratogen is simply an environmental agent that causes harm to the embryo or fetus, if a teratogen is introduced during the pre-embryonic stage or this early germinal phase, then death of the embryo is possible because during this stage the substance is likely to damage all or most of the developing cells. If the teratogen damages only a few cells, the conceptus or the zygote might recover and develop normally. Weeks 3 through 8 of prenatal development is referred to as the main embryonic period. During this time, the organ systems and support systems begin to form. And it's during the embryonic period that the embryo is most susceptible to the influences of a teratogen. Furthermore, it's during this time that the placenta forms, so that the mother's blood supply is now being shared with the embryo. And you may recall, or you may have studied before, the teratogen or environmental agent from West Germany called thalidomide, which was a tranquilizing drug which was responsible for causing over 5,000 malformed births in West Germany. And this was kind of the first study that showed that a teratogen consumed by the pregnant mother during this embryonic period of 3 to 8 weeks could cause pretty severe birth defects. Then 9 weeks until birth is known as the fetal period. So this is the period beginning at 9 weeks after fertilization and continues until birth. During this period, the fetus experiences rapid body growth as well as differentiation of the organ systems. For example, at 9 weeks after fertilization, the fetus is only about 3 inches long and weighs only 1 ounce. However, by birth, the average US baby will be about 20 inches long and will weigh 7 pounds. Teratogens, those environmental agents such as drugs, tobacco, alcohol, introduced during the fetal period generally result in relatively minor anomalies and functional defects. This is because the initial development of the tissues and organ systems has occurred, and this period is mainly devoted to building up tissues and preparing systems involved in the transition for the baby to be born and enter the external environment. So it's that middle period where a teratogen can cause the most damage, because that's when organs and tissues are developing at a rapid rate. Certain drugs and medications can enter fetal circulation and therefore should be taken by a pregnant woman only as advised by a physician. And recreational drugs, prescription drugs, non-prescriptive drugs, and other medications are all chemicals that can affect both the mother and the developing fetus. So we'll look at 4 recreational drugs here: alcohol, cocaine, tobacco, and marijuana, also known as cannabis. So alcohol. Lots of studies have been done on this, as you might imagine. One of the more recent ones showed that up to almost 13% of pregnant women use some amount of alcohol while they're pregnant. More alarmingly is that 2.2% of pregnant women in this one study reported that they engaged in binge drinking, which is in that study defined as 4 or more drinks on any one occasion. So pregnant women often ask how much alcohol is safe. And to quote a statement from the American Academy of Pediatrics, their subcommittee on substance abuse said that to date there is no safe dose of alcohol for pregnant women. In fact, as little as 1 drink per day during pregnancy has been found to be associated with growth retardation. So because of that, they obviously recommend no alcohol for women during their pregnancy. There's been a lot of research done on birth defects resulting from prenatal alcohol exposure, and probably the most studied is the disease or the defect known as fetal alcohol syndrome. So again, this is one of those slides where I don't expect you to understand it, or indeed maybe you can't even read it. But it does show, when I started doing a little bit more research on fetal alcohol syndrome, it shows the interplay of all the factors and the body's reaction to alcohol during pregnancy. So it's pretty interesting. I think this was someone's PhD dissertation looking at the effects of alcohol intake during pregnancy. If you're really interested in that slide and want to break it down a wee bit more, let me know and I can send it to you. So in terms of what's really relevant to us, we need to know what the effects of alcohol are on the developing fetus. And this has been looked at in three main areas. In terms of growth deficiency, the weight and length of children born with fetal alcohol syndrome is below the 10th percentile when it's corrected for their gestational age. They often show microcephaly, which is kind of like a small brain, small head, and they have an increased risk of congenital anomalies. In terms of functioning, they have a weak sucking reflex, they have a lower IQ, increased reaction time, which, if you recall from our earlier lectures, is a sign that information processing speed is affected. They have myopia, which is a visual disorder, irritability, hyperactivity, hypotonia, increased risk for seizures, delayed motor development, delayed language development, and general clumsiness. In terms of facial appearances, they have these small folds around the eyes and may have obstruction of upper airway passages. So you can see that this is very serious, and alcohol consumption during pregnancy can lead to children being born with fetal alcohol syndrome. This is not a recent medical finding. In fact, as this slide shows you, historically, people have known the effects of alcohol on the unborn fetus for centuries. Even though it wasn't medically proven at the time, Aristotle, in one of his writings, told us that foolish, drunken, or harebrained women most often bring forth children like unto themselves. And then obviously another book said, "Behold, thou shalt conceive and bear a son, and now drink no wine or strong drink." So lots of old writings, historical writings, have shown that people were aware of this. They put two and two together. When the pregnant woman was consuming alcohol, their child, when born, showed some symptoms such as we just described on the previous slide. This is a slide showing an image of a brain that's been damaged as a result of prenatal alcohol use. So you can see on the brain on the left was obtained from a 5-day-old child with fetal alcohol syndrome, while the brain on the right was a control brain, a normal brain. The brain on the left suffers from microencephaly, small brain. Obviously something terrible's happened here for them to have access to the brain, and these autopsies have been conducted only on the most severe cases, since these children often have enough problems that they don't survive. But it does show you what's happened here and the difference in the brains between a child who was exposed to alcohol prenatally versus a child who wasn't. Some research has been done on animals, looking at the effect of prenatal alcohol use. Obviously, researchers have been able to do experimental studies on animals that they just ethically can't do on humans. So they've actually injected or force consumed animals who are pregnant to look at the effects. And they found that these animals showed growth retardation. They showed the similar facial characteristics that we see in humans, heart and skeletal defects, small brain, reductions in basal ganglia and cerebellar volumes, hyperactivity, some learning disorders, feeding difficulties, gait problems, and hearing problems. So the same kind of things that we've seen in humans were seen in animals when they were given alcohol prenatally. And you can see this in the picture of this mouse. So this is the facial features of fetal alcohol syndrome in a mouse. And the pregnant mice were exposed to high doses of alcohol during gestation, and they found that the mouse showed the facial features of what we consider facial features of fetal alcohol syndrome. You can see the small eye openings and the long flat area under the nose. So there's been lots of societal efforts to educate women of all ages about the potential dangers of drinking while pregnant. And if we were in a class right now, I might ask you, what would you suggest? How can we get the message out there to let pregnant women and future pregnant women know that alcohol during pregnancy is just not a good idea? Because while this information might seem common sense and not new to you, you're obviously quite educated and quite smart, but there's a large percentage of the population who might not have the same background as you and same exposure to the educational experiences you had, that just don't know, that might not be aware of even what fetal alcohol syndrome is and that what they might be doing to their unborn baby. So some of the ideas that have been put out there is that we build fetal alcohol syndrome education into our K-12 education, kind of like we've done with sex ed and drink driving, that we also talk about this issue. That we continue the federal legislation putting warning on all advertising. That we move that down into state legislature to publicize the dangers of fetal alcohol syndrome. And I'm sure you might be able to come up with some other ideas on how we can educate people about the dangers of fetal alcohol consumption. So we move to cocaine. Cocaine is one of the most dangerous drugs to the unborn baby, and its use in all forms has increased dramatically during recent years, especially during the 80s and 90s when crack cocaine was used quite heavily in some large urban areas. So some facts and some interesting information about the use of crack or cocaine. It's associated with a 25% higher incidence of preterm birth or early birth. It's associated with fetal brain damage, blood vessel constriction, mental retardation, increased miscarriage. So obviously these are really negative, and if cocaine is consumed during pregnancy, it's as this slide says, it's one of the most dangerous drugs. The most devastating effect of cocaine use is fetal brain damage. This damage is believed to be the result of blood vessel constriction causing oxygen deprivation to the brain. And this probably explains why cocaine-exposed babies exhibit mental retardation at that rate of nearly 5 times greater than the general population. Additionally, because of the brain and central nervous system damage, cocaine babies often score low on tests of responsiveness. They perform poorly on measures of instant reflexes, often having poor sucking ability. Sucking is obviously an infant reflex. Their attention span is reduced, making them unresponsive to voices and faces, and they often appear jittery and extremely irritable, and they cry with minimal provocation. This is an older study from 1999, but it's still of interest to us. Arendt and her colleagues, they looked at the influence of cocaine exposure during pregnancy on future motor development. And they reported that 98 cocaine-exposed children performed significantly less well than 101 controls on both fine motor and gross motor indices as measured by the Peabody Developmental Motor Scales during a 2-year follow-up examination. Cocaine exposure independently predicted fine motor deficiencies involving eye-hand coordination and general hand usage. Significant differences in both balance and object reception and propulsion skills were noted within the gross motor scales. Thus, detectable deficiencies in motor development of prenatally cocaine-exposed children remain detectable beyond 2 years of age. The damaging effects of smoking tobacco during pregnancy were first recognized in 1935. And some recent statistics show that between 12 to 22% of women smoke during pregnancy, which, if you're like me, is just absolutely astoundingly unbelievable. We've known that smoking and the adverse effects of smoking, they've been well documented since 1964, when the Surgeon General first reported this and led to warning labels being placed on cigarette packages. And when we talk about the ingredients, and there's over 2,500 different ingredients in tobacco and tobacco smoke, the one we focus on most are the byproducts of tobacco smoke are carbon monoxide and nicotine. Nicotine contributes to fetal hypoxia by causing the adrenals to release epinephrine, a hormone capable of constricting the placenta's blood vessels. Carbon monoxide is known to interfere with the hemoglobin's oxygen carrying and oxygen releasing capabilities, and therefore increases the risk of fetal hypoxia as well, which is just the lack of oxygen to the body tissues. So that's what's going on here. There's a lack of oxygen being released to the body's tissues because of these ingredients in this tobacco. Cannabis or marijuana is a mind-altering drug composed of more than 400 different chemicals. And the one we talk about most is THC. And interestingly, there's been little conclusive research on the effects of marijuana and its effect on the human embryo or fetus. So even though there's tons of research out there telling us about the negative effects of alcohol and tobacco during pregnancy, there's little conclusive research showing that marijuana has any kind of effect on the human embryo or fetus. And in fact, some organizations have stated that there's just no known obstetric complications involved with marijuana. However, as you might guess, medical professionals and doctors recommend that pregnant women refrain from the use of all recreational drugs. Okay, I think I'm going to skip that slide. So I'm going to move on to look at some genetic factors that might affect prenatal development. Genetic factors affecting normal prenatal growth and development can take one of two forms. That is, abnormal development can be caused by chromosomal or gene-based disorders. And for the purpose of this course and this lecture, we're going to focus on chromosomal disorders, particularly looking at Down syndrome. Now, some of you might be familiar with Down syndrome from your other classes or from personal experiences, so we're just going to provide an overview here. You will study more about this in several of your other classes. The information I'm discussing was taken from a lecture by one of my former mentors and teachers at the University of Virginia, a national expert on adapted physical education, who's done a lot of research on motor development of children with Down syndrome. So, what is Down syndrome? It means that the child is born with an extra chromosome in each of his or her million cells. So we know that every normal cell within our bodies contains 46 chromosomes, with the exception of the reproductive cells, which contain only 23 chromosomes. When the sperm and ovum join during conception, each contributes its 23 chromosomes to form a new individual whose cell will also contain the usual 23 pairs of genetic material. So, without going into too much biological detail here, something happens whereby one of those chromosomes there's an additional one. So instead of 46 chromosomes, the 23 pairs, one of those pairs has an additional chromosome within it. And that gives the Down syndrome fetus and child 47 chromosomes. Usually the extra chromosome is in the 21st pair of chromosomes, and you'll see that on the next slide. I say usually, that's not always the case, but it usually is. This extra chromosome causes genetic imbalance which alters normal development. This was first reported by Langdon Down, as in Down syndrome, in 1866. So here you can see the 23 pairs of chromosomes, and you see in the 21st one there's just an extra one in there, so there's 3 in that pair. So different types of Down syndrome. There's 3 main types. Trisomy 21 is the most common, and up to 95% of children with Down syndrome fall into this category. And this is reflected in that previous slide where there's 3 instead of 2 chromosomes in that 21st group. The other types of Down syndrome are known as translocation, which makes up another 4% of cases. Here the extra 21st chromosome is actually attached to another chromosome, which is usually the 14th or 22nd. The total count will be 46. 1/3 of these cases are inherited. And then mosaicism is where some cells have an extra 21st chromosome while others are normal. And children with mosaicism often have less severe features than trisomy 21. So I don't know how much of this is really important for you to know, but I would just hope that you recognize or take from this slide that there are 3 types of Down syndrome and that trisomy 21 is the most common. So as we look at trisomy 21, the most common type of Down syndrome, the most common features of this are that walking is delayed by 2 or more years, that speech development is slow, that there's slow development of fine motor control, toilet training is delayed, lower than normal birth weight, hypotonia, short stature, puberty is delayed. They're prone to respiratory infections, heart disease, which is obviously very serious, and some prominent anatomical features which make them look different, which we'll look at in the next few slides. So the exact cause of Down syndrome is unknown. There are some factors that we know that make people a wee bit more at risk for Down syndrome, but the exact cause is still unknown. The incidence is somewhere between 1 in 600 to 1 in 700 live births per year in the United States. It's the most common chromosomal abnormality that allows embryonic development, i.e. the fetus continues developing. And we know that the chances of Down syndrome, having a Down syndrome child, increase with maternal age. As you can see, at the age of 20, it's 1 in 1,500, which increases up to the age of 50, where it's 1 in 10. So with age, the chances are of having a child with Down syndrome definitely increase exponentially. In terms of Down syndrome and development for intelligence, children with Down syndrome function as a person with mental retardation. That extra chromosome affects their brain development. They have an IQ of around 40 to 55, which is way below the threshold for mental retardation. Children, however, with the mosaicism do have a higher IQ. Their social maturity is often greater than their IQ, so even though cognitively they might not be able to understand things, socially they are able to act appropriately in different situations. And then the most important thing on this slide, and perhaps all of these slides on Down syndrome, is that early intervention, high expectations, and better teaching have improved the IQ and the general outcomes of people with Down syndrome over the past 30 years. So whereas 30, 40 years ago, children with Down syndrome were kind of written off, maybe put into special schools or special homes, We now realize that integrating and including these children into regular classrooms and providing lots of early stimulation and interventions for them can lead to better outcomes for these children. And if you're lucky enough to take PD 415, you will have experience working with children with lots of different disabilities, including some children with Down syndrome, and you will see how they respond to interventions and high expectations and how they can improve on different motor skills and cognitive skills with practice, just like the rest of us do. One of the most visible characteristics of Down syndrome children is their muscle tone. They have low muscle tone, which is known as hypotonia, and they also have tremendous flexibility or joint laxity. These children are often referred to as floppy babies because of this joint laxity. We see an increased range of motion in joints and diminished resistance of joints to passive movement, and they're able to sit in or move into very unusual postures. And a lot of kids with Down syndrome quite enjoy showing you that these different stretches and postures that they can maneuver into because of this increased range of motion. In terms of facial features, I'm sure you've all seen someone with Down syndrome before, so you can picture this as I'm describing it. The nasal bridge is flatter and smaller, which can affect breathing. The eyes appear to slant and have small folds of skin in the inner corners. The mouth appears small and the roof of the mouth may be shallow. So when accompanied by low muscle tone, this can often result in the tongue protruding. Teeth may come in later and in unusual order, and the ears are small and the tops of the ears may fold over. They may be slightly lower on the head, and the ear passages may be small, causing some hearing loss issues. In terms of stature, the physical growth is abnormally slow and often stops early. And people with Down syndrome tend to be short, often only reaching a height of 5 feet or less. One of the major issues with Down syndrome is cardiac problems. 40 to 50% of people with Down syndrome are born with some type of heart issue, and it's the major cause of high mortality within children and infants with Down syndrome. The most common defects are ventricular septum defects, which is a defect in the wall of the septum between the right and left ventricles. Sensory problems. Children or infants with Down syndrome have issues with vision, cataracts, and stigmatism, as well as nearsightedness. Hearing. Children with Down syndrome have quite commonly hearing problems and experience lots of ear infections, and also have issues in tactile discrimination and copying figures and in balancing and quick movements. So in terms of when they move into infancy, we see these extreme delays, but they tend to follow the normal course of development, just at a slower rate. We see lots of hypotonia, delays in emergence and integration of reflexes and automatic movement patterns. However, once again, and this might be the biggest take-home message here, is that early intervention can improve their motor development. So these children need to be shown how to move correctly and how to produce these skilled movements. As these children move into childhood, out of infancy into childhood, they tend to fall a little bit further behind their peers. All areas of motor skill development will be delayed because balance is primarily an issue. We see poor fitness, including an increased risk of obesity. We see major differences compared to their age-related peers. However, some research has shown recently that children with Down syndrome do have a pretty good rhythm, which is quite interesting. As they move into adolescence, we see some improvement in tone, strength, and stability. They can learn age-appropriate recreational activities, which is when you speak to the parents of children with Down syndrome on their IEPs or their individualized education plans. They often want their children to learn and have the skills to engage in recreational activities. They can follow rules in both individual and team sports. However, we see continued problems with obesity and fitness. So getting these children moving, physically active, and eating the right foods and following good nutritional plans is quite important. A couple of few slides here that may be more relevant to some of you than others. So if you're working with someone with Down syndrome, either as a patient or as a client or as a student in a class or individually, we need to think of some accommodations that you would make to help that child be successful. And there's no magic formula here. It all depends upon the child. So you need to think of the child or the person rather than the characteristics of the disability. So we can't say, oh, this person has Down syndrome, we need to make this modification. You always have to think about the individual and focus on their strengths and abilities rather than what the disability says they cannot do. For those of you going into physical education, you will be teaching children with Down syndrome. They will be included into your regular classes, usually without any kind of aid coming with them. That presents some challenges, but it also can present some of the most rewarding experiences that you will have. You do need to make accommodations for them for any kind of activities that you do. I would argue, however, that good physical education is good adapted physical education, because we should always be differentiating and individualizing our instruction for people at different skill levels. So making these kind of accommodations would just be maybe one step further to help these children be successful in your classes. In terms of instruction, you need to keep verbal directions to a minimum, use extra demonstrations, provide a very supportive environment, maybe think about where you position them so they can see and hear you because of their disability, maybe have a peer helper assigned to them, and provide activities that ensure success so that these children feel success, feel good about themselves, which psychologically is going to make them want to participate more in those activities. So here's some specific accommodations for different sports, how you would just modify to help children with Down syndrome to be successful. Okay, changing gears into the last little section of this lecture, 3 or 4 slides left, I believe. So even though we're looking at some very negative things, alcohol, tobacco, cocaine, Down syndrome, we should know that only about 4% of children will be born with any kind of abnormality. So I know this is a quite depressing lecture, but recognize that only 4% are born with any issues. However, through prenatal diagnostic procedures, we can detect these abnormalities ahead of time. Now, this won't lead to any kind of cure for the prenatal abnormalities that they detect, but they can alert expectant parents and healthcare professionals of the need to take special precautions for the remainder of the pregnancy. And for some, these tools may provide valuable information in deciding whether to continue with the pregnancy. So these prenatal diagnostic procedures are often given to pregnant women who might be considered for at risk for giving birth to a child with abnormalities. These might be women over the age of 35 at the time of delivery. They might have already given birth to, or as a partner who has, a child with a genetic disease or birth defect. They may have a family history of genetic disease or birth defects, or has a medical history of certain genetic traits such as sickle cell anemia or diabetes. So let's look at some of these prenatal diagnostic procedures. You may have seen or heard or maybe even experienced some of these before. So ultrasound, also known as a sonogram, is administered by placing a small transmitter on the abdomen of the pregnant woman. The abdomen is often lubricated so it can be easily maneuvered into the position that enables for the best position to see the fetus. So the transmitter, as you can see in this picture on the slide, emits high-frequency sound waves that echo off the fetus. In turn, those sound waves are transformed into computer-enhanced images on a monitor. So it can be used to examine the placement and structure of the placenta, as well as to detect the baby's gender, multiple pregnancies, and some anatomical abnormalities. The advantage of the ultrasound test is that it causes no pain, no injection is required, and it only takes about 30 minutes. And according to the American Institute of Ultrasound and Medicine, there are no confirmed adverse biological effects on either patients or operators. Unlike ultrasound, amniocentesis requires a needle to be inserted through the abdominal wall. This procedure was first used for fetal diagnosis in 1967 and employs a thin needle to remove approximately 2 tablespoons of amniotic fluid drawn from the small amniotic sac around the fetus. This fluid contains fetal cells which can be examined to determine the presence of some abnormalities. Because this is an intrusive test, ultrasound is used to locate the best site for the puncture. Although amniocentesis is believed to present minimal risk to the mother and fetus, the needle has been known to damage the fetus on occasion. In addition, amniocentesis has caused miscarriages in approximately 1 in 200 pregnancies. The process takes about 20 minutes and can detect numerous chromosomal abnormalities such as Down syndrome, the gender of the baby, and neural tube defects such as spina bifida, with a high degree, 99% of accuracy. So here you can see the ultrasound equipment being used to guide the needle. It's inserted through the abdomen into the area where the amniotic fluid is drawn for analysis. So hopefully that needle is not coming into contact with the fetus. Chorionic villus sampling, known as CVS, is a technique that offers one major advantage over amniocentesis. It can be administered between 10 and 12 weeks of gestation so that abnormalities are detected earlier. So this is done earlier in the pregnancy. CVS is designed to gather cell samples for examination. However, rather than sampling the amniotic fluid, it's intended to take samples of the small hair-like projections of the placenta. It's administered through inserting a needle through the abdomen and again uses ultrasound to guide the needle. So even though it offers the advantage of earlier administration and earlier detection of abnormalities, it's potentially riskier than amniocentesis. 3 times as many miscarriages are caused by CVS than amniocentesis, with 1 in 100 CVS administrations causing problems. Therefore, it's recommended only for the highest risk pregnant women. Okay, that brings us to the end here, so let me just add a few summary statements. So both genetic and environmental misfortunes can alter the normal fetal growth and development process. And we talked about how drugs and medications consumed during pregnancy can affect the developing fetus. And there are particularly damaging at certain times during the pregnancy, especially during that main embryonic period of development. So women should not use recreational drugs during pregnancy, and we talked about different types. So again, even though this was pretty negative, there are other factors that positively affect prenatal growth, such as exercise and nutrition, and I know you'll be looking at those in some of your other classes. That concludes this lecture.